Hello everyone, and welcome back to the final session of our conference, where we're pleased to welcome and invite Bethan Page and Dr. Emily Harrop from the University of Oxford and Helen and Douglas House, Oxford, to present on their study about improving support to parents caring for children using medical technologies and who are medically complex. If we've time, after Beth and Emily have finished presenting, we'll take questions, but it is important to leave time for Dr. Helen Dunbar from Together for Short Lives to wrap up what's been an absolutely fantastic conference. But so without further ado, I'll hand over to Bethan and Emily. I'm not quite sure the order you're speaking, but we'll just sit back and enjoy. Over to you, Emily. Thank you very much.
So my name's Emily Harrop. I'm a consultant in children's palliative care in Oxford and the medical director of Helen and Douglas House. I'm co-presenting with Bethan Page, who's a doctoral researcher at the University of Oxford, on improving support for parents caring for children with medical complexity. So what do we mean by this? Well, the range of procedures or medical interventions carried out at home has increased exponentially in the last few years, really. And if you look at this pyramid, that ranges from activities such as supporting the normal care for daily living activities, so dressing, eating, personal care, through to monitoring bodily functions, delivering feeds artificially, either intravenously or through tubes, and right up to life support with all sorts of ventilatory input at home, whether by face or via tracheostomy. So that goes from the kind of care traditionally done by families and lay paid carers all the way up to the kind of care traditionally done on intensive care units. And this is because more and more children are surviving from premature birth, complex congenital abnormalities, inherited and acquired diseases, and also from major trauma. Most of this care is being done at home by families. They may have paid carers, but actually it can be very difficult to fill those care packages. And even when you do, carers will go off sick and can create short notice further burden for families. So what challenges do these parents face? Well, these are some quotes that Bethan and I got from interviews with parents whose children had major abdominal surgery in the first year of life. And they demonstrate a number of themes, starting with the responsibilities of the parent, the impact on the family, and also the journey traveled by those parents. So beginning at the top, this quote, and the first time I pulled the NG tube out was in the middle of the night, in the dark, 2 days after we brought her home. It was awful. My husband pinned her head down and I jammed the tube in, hoping that I didn't hit her lungs and that I would hit her stomach. So this illustrates, the need for medical procedures, having to intervene with emergencies, having to coordinate that care, and also advocating for that child. Just the exhaustion of trying to look after him just got increasingly tough and unmanageable, and actually to the point of being quite dangerous. And here the impact on the family has parents not being able to go out, constraints on time, lack of sleep, impact on siblings. Don't undervalue the amount of time and energy that parents put into trying to find out as much as they can, and also knowing their child inside out and back to front. And this highlights the new normal for parents, becoming an expert. And we've heard talks today on how important it is to acknowledge that expertise among parents who have looked after a child with such complexity. So the agenda for our talk this afternoon, Bethan and I are going to talk briefly about some hidden incidents that we have analysed, looking at the National Reporting and Learning Service incident reports for this sort of care at home. Bethan will talk about patients' experiences of training and support, and we'll look together at what we can do to help families and how we've progressed this so far. So looking at these incident reports, firstly with regard to long-term ventilation. So here, this study identified from the NRLS database a large number of incidents, 40% of which resulted in actual harm to a child being defined by the person reporting. There were 220 of these over a 5-year period. And the common themes that were identified were the need for training for staff and other carers to be improved, maintenance and availability of appropriate equipment at short notice, support for families, and coordination of care. Some examples of quotes that I found quite hard-hitting from these reports included a child who was on long-term ventilation on a flight back from holiday requiring ventilation. The portable ventilator failed after 15 minutes and the child had to be woken up and kept awake just so she could breathe unaided. Also, a community patient who was quadriplegic and ventilated via a tracheostomy, who was unable to summon help when he needed airway clearance, was at home in bed and unable to get the support he needed. He had very limited verbal communication, and this was obviously worse when his airway was compromised. And what I did notice from some of these reports was it could be quite hard to know exactly what the outcome had been in some cases. We also looked at NRLS data for enteral feeding tube incidents at home. There was a large number of these also, and only half as many resulted in actual harm to the child, so about 19% of the 274 incidents. However, some of the themes identified for improvement were very similar. So again, communication, in particular handover from hospital to community, training for family carers, provision of expertise in the community, and availability of reliable equipment. So it all comes really down to communication, coordination, training, and equipment. So Bethan's going to talk now about parents' experiences of training and support and some of the work that we've done to date.
Okay, so Emily has talked a bit about the background to this work, but what we're going to share with you now is some of our progress and what we're actually done to improve the situation. So what we wanted to do was really understand the experiences of these parents. So the incident report data Emily talked about was mostly the concerns of the nurses. But what do families, what are their experiences when they're doing medical procedures for children at home? So we started doing a survey with 50 families who did a range of different medical procedures for the children. So this included feeding tubes, home oxygen, long-term ventilation, tracheostomy care, bowel washouts. And we asked them about their training and also how they thought that their training and support could be improved. So what came out from this? Three major themes. First of all, that parents felt really quite scared and unprepared in the first few weeks at home. This ranged really from feeling a little bit scared to absolutely terrified and out of your depth. This parent says, terrified we would do it wrong. We weren't really sure what was right or wrong. Parents' descriptions of training for the procedures that they were now doing for their children at home were really variable. There was some very in-depth, thorough training, and there were some parents that really hadn't had much practice and training. And the emotional impact on families is enormous. The anxiety, the doing procedures which are distressing or invasive for children, and the worries about other siblings and leaving your child with another family member and who you can trust. So we focused then on gastrostomy care. So the focus on gastrostomy care was because these families, there's a huge number of them now across the country. And actually the training for gastrostomy care is often quite short. So compared to something like long-term ventilation, parents with gastrostomy surgery, they might just be in hospital with their child for a couple of days. And then they're at home with varying amounts of support from community nurses. So when you look at how confident people said they were in the first few weeks at home after surgery, you can see that considerable numbers were really not at all confident or only slightly confident. So we wouldn't expect all parents to be fully confident, but that's a huge number of parents that are actually feeling very underconfident and anxious when they first go home after surgery. When you look at the types of training that parents have received, this is mostly, unsurprisingly, verbal information and demonstrations, often on very busy hospital wards. About 50% of parents were given written booklets. Only 13% had some simulation practice, so practice with equipment or dolls. Very, very small numbers were directed to videos or further information like demonstrations from family members. So we can see here that the training is quite variable, and even something like written booklets, actually quite a lot of parents said, or at least didn't recall being given any written information. So just to read out a few quotes, some examples of training that was seen as poor quality by families. Minimal training, was shown once in hospital, observed giving meds and then sent on our way. Very little training indeed. I would say 95% of what I learned was through parents on Facebook groups for tube feeding. You can see an awful lot of parent-to-parent information sharing and learning going on in these Facebook groups. We didn't get much practice before being left to do it on our own, so you were triple checking yourself and worrying, did I do it right? And this parent says the first time that they experienced granulomas or overgranulation, they thought their son's intestines were coming out. Nobody had ever mentioned it, and she hadn't seen anything like that before. So actually parents do really need preparation for the kind of troubleshooting stuff as well as the routine care, and this can cause a lot of anxiety. So what types of training do parents recommend? So unsurprisingly, the vast majority of parents were rating supervised practice on their child and face-to-face teaching with clinicians as extremely or very useful. But interestingly, about 2/3 of parents rated videos and simulation practice as extremely or very useful. Yet we know that very few parents are actually getting access to this as part of their preparation. So in terms of what might be most useful to families, in addition to the face-to-face training with clinicians, is the videos and the simulation training in particular, less so the online training or group training that we presented as other ideas. So suggestions for improvement. Parents had so many suggestions for improvement in the survey. I'll just read out a few. I think we should have had more training before his surgery and not while he was in theatre. As we were so anxious, I'm not sure how much we took in or how valuable doing it then was. I think this is critical because at the moment, a lot of training is in that hospital admission of just a few days. And it is very stressful for a lot of families. And would you retain all that information when you're actually worrying about your child's health and well-being? Really useful being able to play with a tube and practice using the clip, etc., before having to do it for real. This is a parent who had practiced what we called simulation practice, so they're able to get familiar with the equipment. I think there should be a process in place for parents to receive more formal training in regards to caring for the gastrostomy or jejunostomy. This is complex and I do not feel there is enough time and money put into this. When we think about the amount of training and the signing up of competencies that's given to anybody that's paid by the health and care system, and we compare that to what's given to families in some cases, it really is quite striking how little preparation some families are getting. And this parent says that they think the videos are really good resources that parents can go back to, but that they're not a replacement for face-to-face training, they're there to supplement it. We showed an example video with Tanya and her son Dylan here that you can see in the photo. Tanya's worked with us over the last few years. So we said, what kind of videos would you want if we created some videos for gastrostomy care? And 60% of parents said they should be filmed in the hospital and in the home, so a mixture of both. And then 37% actually said all the videos should be filmed at home. Who should be in the videos? 80% wanted both healthcare professionals and parents to feature, so this is critical. There are some existing videos we found on YouTube. Mostly they are filmed by healthcare professionals in a sort of, we are the healthcare professional and we're teaching you way, whereas the video we showed was very much Tanya sharing her knowledge as a mother with other parents. So this went down very well. Parents rated different topics for videos. Well, nearly all of them were rated as very helpful by a majority, but troubleshooting topics in particular were highly rated. There's a quote from the parent on one of the videos here. It's lovely to see it happening in a natural environment where everyone is relaxed and it is all very normal. So what can we do to help? I'm going to talk a bit about some of the work we've done in the last year or so, really, to try and do something practical to help. So we got some funding through the Health Foundation to try and develop some videos and simulation practice with families. So this is mostly based at the John Radcliffe Hospital in Oxford, where we've been piloting things. So we've now got a library of 19 videos at last count, which really follow the trajectory of parents' needs. So they start from introductory videos. There's one of Emily talking about why do children need gastrostomies as a paediatrician, and it follows right through what will happen in the surgery, the kind of routine care tasks, the troubleshooting, what happens if the site is leaking and sore, granulation tissue, and topics such as blended diet that parents told us were very important to cover. So the videos feature people from the hospital, community nurses. They feature lots of different parents, some of whom are teaching and some of them are sharing their kind of experience and tips. So there's really a collaborative effort featuring the different parts of the system and the different parts of the professionals that families will come into contact with. Simulation practice, this is a photo here that you can see of a mother practicing with some equipment. We got some 3D printed models here that you can just see one side of, but the other side you can see the balloon. And parents can practice basic things like connecting the extension tube, changing the water in the balloon. And really there's a huge emotional impact for parents who are new to this, because it's an opportunity to practice without fear of hurting your child and to become familiar with something before you then first try it out on your child who's just had surgery. So the simulation practice, I think, is really helping parents' confidence. On our website now, if you're interested, do search. It's through an organisation called Oxstar, which is a simulation centre based at the hospital in Oxford. We've got all the videos up there now and various other things, such as a list of resources that parents have shared with us. For example, stories about gastrostomies, how to explain them to your children, links to Facebook groups, just other helpful resources that parents have, more expert parents and more experienced parents want to share with new families. There's also a mini quiz here written by a couple of the nurses. In fact, the quiz actually links you back to videos. So if you're not sure about an answer, it takes you back to the relevant video to watch. Evaluating the videos. So the first question is, do the videos actually help learning? So we basically recruited 150 odd parents who didn't know anything about gastrostomy care, so kind of naive people of parent age. And we gave them either the written booklet that they would normally get for caring for a gastrostomy at the John Radcliffe Hospital, or they got given the booklet plus some additional photos and some key information repeated, or they were given the videos as well as the booklet. And when we did a test of their knowledge, performance was best in the group who actually watched the videos as well as read the booklet. But interestingly, adding photos and repeating key information did also help. So clearly the videos can help learning, but what do families who are actually going through gastrostomy surgery and who have experience of caring for a child with a gastrostomy think? So we've had some ratings here from about 35 families at the moment. We're continuing to evaluate them. 92% felt that the video, strongly agreed that the videos would be useful to families new to gastrostomy care. And 80% strongly agreed that they would recommend the videos, with another 16% saying somewhat agree. Interestingly, a lot of the parents that completed the survey that we classed as experienced parents actually learned something new from the videos as well. For example, the granulation video by the specialist nurse at the hospital, there were things that experienced parents were learning that was new to them. The mixture of healthcare professionals and families, 92% of people that watched this felt strongly agreed that there was a good mixture. I think that's what's quite unique about our set of videos. And the information in the videos is easy to understand. Again, strongly agree was 80% of parents felt that. So one area that is tricky to get right with creating videos is the consistency of information between different areas. So we had a few small number of parents, so the vast majority did somewhat agree or strongly agreed that the accuracy of advice and the information was consistent with the training they had received. However, you can see there's a small number of parents that have picked up on differences in guidance. So this parent says the only risk is that different areas may have different guidelines around certain procedures, so it may be confusing, especially for someone new to gastrostomy. For instance, we were always told to flush after a feed, not before and after, while the team who trained our son's school taught them to do it before and after. So there are lots of small differences in practice, and experienced parents know what's kind of important and what's a small difference. Whereas actually for new families, it can be quite anxious. They can become quite anxious when they're given different information by different people. So that's one challenge of creating the videos, getting that information right. And we've reviewed them now by a number of different professionals from different parts of the system, helping us evaluate the videos. We're continuing to evaluate them at the moment, mostly with healthcare professionals now, but also with some additional families. So if you'd like to get involved, please do send me an email and I can send out the survey to you. So I'm about to pass back over to Emily, but just before I do, I just want to share a few things that stood out for me about the project. So one thing that's really worked is working with families right from the conception. So we started from meetings with families and healthcare professionals, really thinking what might help. And you've really got to start from families' needs. Guidance and best practice is really quite variable. The more we look at this, the more differences we find. Working across professional boundaries is key across the hospital and the community services. And parents have been so willing to help. They've created videos for us. They've given us feedback. And really, I think when parents feel there's a benefit to other parents, they're very happy to get involved. And it's not just about training and routine procedures. Parents also need to learn from other parents. There's all the tips, the advice, the expertise of other parents that really so helpful and so valuable. We can't just be delivering training from the perspective of nurses. Help with troubleshooting, that's so critical. And I think for gastrostomy care, some parents are getting good support from the community nursing team, and some, the expertise is perhaps patchy or the services are overstretched. So really, we've got to think about how we can help and support parents with troubleshooting. And if we give parents information, say 6 months ago, and then 6 months later there's a problem, they might not necessarily remember what the information they've been given. It's just really helpful to have videos that you can revisit as you need. So I'll just stop sharing now. Emily, actually, shall I keep this slide up?
Yeah, so, and you'll be able to click on when I get to it. That's perfect. Thank you, Bethan. So just to round up really, what else can we do and how can we do this better? I think it came through as a theme that it's going to be really important to relieve some of the burden for parents, particularly around coordination of care, which they strongly perceive that they are the advocate, sometimes the only advocate for their child. Emotional preparedness and support needs to be a part of the training. So I think some parents feeling that technical skills are being covered, but not the burden on them emotionally. We think maybe some other training resources and videos would be useful. Maybe looking at other medical procedures. We haven't yet covered things like the ventilation or some of the other things going on at home. I wondered, particularly in palliative care, pain management perhaps might be something that we can give some more structured support for. Perhaps managing a child's distress generally during a procedure would be a good area to target. And also some support in navigating the health and care system. So coming back to being that linchpin, that advocate for the child. One thing that I suggested to Bethan was, much as families can report into the NRLS, where we got our incident reports from, and can also report to the HSIB, I don't think they do. It's not very parent friendly. If you look at the links we've put on there, it doesn't really invite you as a layperson to want to report your experience. So I think that it would be amazing to have a dedicated family friendly interface community incident reporting system. And if you all think about the number of patients on your caseload for whom there just must be near misses and incidents happening near daily, I think the information we could get to improve the life experience for those children and their carers could be absolutely massive. And I'm going to do a Chris Whitty now and say, next slide, please, Bethan. And so here to finish is Siobhan, one of our nurses from Helen and Douglas House, who was involved in this project and made some of our wonderful videos incredibly expertly and much more glamorously than me, with Polar Bear, who is a bear that Mr. Alex Lee, one of our co-researchers, operated on numerous times during the videos as well, as it was feedback from a family member that having plastic dummies was not very child friendly, and that sometimes the 3D printed body parts didn't feel that family friendly either. So we hoped that Polar Bear would be so. So just to conclude, I think this research felt incredibly family-centred. It really was done by co-conception, and that very early ideas for this came from a wider group we'd had around complex care at the Academic Health Science Network Patient Safety Group. So thank you, Bethan, for presenting that so beautifully. And if there is any time, we'd be happy to take questions.
Thank you very much, Emily and Bethan. That was a really interesting presentation, and I think lovely to finish this conference reporting a study which started with sort of the gathering of the evidence in partnership with families and has ended up with, you know, intervention that families are finding helpful. That's a really lovely way to end the conference, which is what all of our research really is all about. We've had a couple of questions, and we've got time for a few. Somebody was asking about why you think, I mean, when you're presenting, it's like, well, this is so obvious. Why you think it hasn't been picked up before, these kind of unmet sort of training and support needs of parents?
I mean, I think, you know, you can comment as well, Bethan, but it's very easy as a healthcare professional to see the situation just from a healthcare professional point of view, isn't it? And I remember the first time that I met Professor Charles Vincent, who supervised Bethan's PhD, and he's obviously an expert in hospital patient safety, but just explaining to him some of the things that happen in the community, he'd no idea, he couldn't believe it at first. So I think if you don't appreciate the enormity of the risk out there, you don't go looking.
Yeah.
And I think one of the things that comes out is this variability in parents' experiences. There are some parents that are, you know, getting some fantastic training, but it is so variable. And actually, if you provide training in hospital, or you've got, say, a supportive community nursing team, but your training in hospital wasn't good, there's so many parents that fall through the gaps. And it's just, yeah, there's no kind of updating or refresher knowledge like you often have with healthcare professionals. There's no checking up. So often we're just not aware of the problems. And sometimes parents, I think, are sort of told off when they're not doing something right. And actually, you know, that is because they've not been given adequate training or support, or it's been delivered when they're very stressed and they've forgotten things.
Yeah, I mean, I think that the issue of the sort of the topping up and of training or new developments in equipment's an interesting issue, isn't it? Because I guess quite a lot of the time parents are doing these procedures without anyone watching them, that they're just happening, you know, unobserved in a sense. So that's really interesting. Quite a few people have asked where they can access these videos, but I think that's, you've signaled that in the presentation.
Yeah, the Oxstar website is the place to search. OXSTAR.
Lovely, and perhaps you could just pop that in the Q&A as well, please. Thank you. Yeah, so lots of very positive comments and excitement, I think, about this resource, and perhaps the way that other localities could be using it. And I'm sure you'd like to hear if people are doing that. I wondered whether there was anything that you came across in terms of issues around equipment and how frequently that was being checked.
I mean, there were lots of things, weren't there, Bethan, in the NRLS work and in some of the interviews about equipment that was either missing or faulty or was not available in a timely fashion. So yeah, I would say that was really important.
And are there systems where equipment's sent into sort of families' homes where, you know, there's a sort of system by which a sort of maintenance check is carried out?
It's very hit and miss, I think, you know, so some types of complex home care come with a sort of aftercare package. So, you know, home ventilation, they talk about, oh, you'll have a gold aftercare service, or, you know, various types of support, but it's not always particularly consistent. Certainly with enteral feeding, you know, I think that's considered lower risk. And in fact, our data rather supports that, but still can pose a significant risk of impact on the family.
Yes. And I'll sneak in my final question before we finish, is when you talk about giving parents access to parent stories, I wondered whether that included sort of the parent-led groups sort of on social media. It's something we've come across in the study of diet and tube feeding, and how they're often these parent-led groups around sort of use of blended diets. And I wondered whether you'd sort of made sort of use of those in the sort of resources you were suggesting to parents.
Yeah, so we're actually guest professional members on, for instance, the blended diet group. We asked, through the administrators properly, we're not spying on anyone, but it's been a really rich source of information, hasn't it, Bethan? And
definitely, I think if you think of incident reporting data, which is really a list of concerns, the social media groups do give you a list of concerns, and actually that's often the place that parents go to express concerns. So I think as a way of the best way we probably got at the moment of understanding parents' concerns is the surveillance through the social media.
Lovely, thank you both very much. I'm sure you'll be hearing from quite a few of the participants to sort of learn more about your resources. So thank you both very much indeed. I'm going to hand over to Lorna now, who's going to lead towards wrapping up.